emphasize 5 out of 5 strength or 130 degrees of knee flexion. They care whether you can go up and down stairs, can you go from sit to stand, can you ambulate, can you do this, can you do that. So it's all about function to them, and that's fine. That's what our goals should be. From a PT standpoint, I need to write functional goals. Now I may have a range of motion goal in there, or even I would never put a manual muscle test goal, but I will always have functional goals, and most of the time I'm going to do this through these functional scales. When my wife and I owned our clinic, a person came in with low back pain, they would fill out an oswestry. We'll go over that one in a few minutes. At the time of admission, their first visit, we would do it intermittently. You know, if they were there for a long time, we would do it at least once a month. And then at discharge, say if they were there for 6 weeks, they would probably get it 3 times, okay? I know of places that make people fill out the functional index every single time they come to therapy. That is nonsense. And that will, I mean, if that's me, I'm not going to therapy there, because that's just a waste of time. You're not gonna make significant functional gains each time you go, unless you're going once a month or something like that. So anyway, it does provide documentation. They are relatively efficient, effective, and easy to use for the most part. You'll see some that are and some that aren't. They should reflect appropriate measures, patient population, space, equipment, time, all these kinds of things will be appropriate for each category or diagnosis, okay? So let's jump into a couple of these. Berg balance scale, used more than any of the balance scales that you're going to see. This is kind of the gold standard, has tremendous research behind it, helps to predict falls in the elderly. Objective measure of static and dynamic balance abilities. What is static balance? Give me an example of static balance. Standing on 1 foot. That's a good one. Okay. Can you stand on 1 foot? What about dynamic balance? Well, you got to think about the population that we're dealing with here. We're not going to have, for the most part, elderly folks or people with balance problems doing really, really complex things. How about just bending over and picking something up without falling on your face? Okay, that's more the dynamic balance. 14 functional tasks. I'm going to pull it up, let you take a look at it. You don't need to memorize it, but you need to be familiar with it. You will see a board question or two on this, I promise you. So let me find this. We won't do this for every one of them, but just the big ones. And feel free, if you want to print these out, whatever, feel free to do so. I don't think it's necessary. I'll give you a little scan of it real quick and we can go from there. The 14 tasks start very, very easy. Come on. Let's turn on anything faster. Okay. So, sit to stand, try not to use your hands for support. Most people are going to be able to handle that, but there's going to be some that can't. You rate that from 4 to 0. Standing unsupported. Sitting with back unsupported, with feet on the floor, like on a stool or on a low table like such. And you see, these get a little bit harder as we go along. Then we get the transfers, more dynamic stuff. Okay? Reaching forward with outstretched arms while standing. Stand and reach test. It's pretty standard as well. We'll talk about that one as well. Turning 360 degrees. This one starts to get interesting here, okay? You get people all over the place. You're gonna want to have them in a gait belt for this. And again, you'll talk about more about this in neuro. So the total score, 14 items, 4 being the most on each one. Total maximum score will be 56. Now, what you need to know is this kind of thing, the interpretation. Low fall risk for 41 to 56, excuse me, on this scale per se, okay? So if on the board they'll say something like, so-and-so scores a 38 What kind of fall risk are they? That is a medium fall risk, okay? If you've got somebody that scores in the teens, high fall risk, right? So those are the kind of parts of the scale that you need to know. If you commit to memory, you're not going to need to know every one of these items. It's more about how you score it and what's important with those, okay? Okay. Any questions on bird balance? Okay. We can practice. What we'll do is we'll practice one of these tomorrow, and this will be our soap note. Functional reach test. Again, really pretty simple. How far can they reach forward with the feet kept together? It's a really good test of static balance, but actually having them do some type of functional task as well. If they cannot reach at least 7 inches, and the way you measure that is they have to hold the arm up and then you hold a ruler or something here. If they can't go at least 7 inches, that usually means that they are at high risk for this, okay? Less than 18.5 centimeters, talking about falls at that point. So again, we're not going to go over that test. Just know some basics there. Timed up and go or a tug, you will see a great deal in nursing homes and on acute care floors and so forth. But we can do this in an outpatient setting as well. It is really, really simple. Start from the seated position, stand up and walk at a normal pace, and turn around and sit. And you just tell them to go as far as they can go and come back. Excuse me, that's a different test. Stand and walk 10 feet at a normal pace, turn and return to the chair and sit down. How fast can they do this, okay? Most people without balance problems can do it in less than 10 seconds. If they're functionally independent, they can usually do it in 20 or less. At risk for falls greater than 30 seconds and needs an assistive device, okay? Mean score, community dwelling, elderly patient, 8 to 15 seconds, okay? This has been tested over and over and over. So a tug is something that you're going to see. Dynamic gait index, I don't see this nearly as much. Again, help to predict falls in adults and individuals with vestibular dysfunction. This is more specific for that. I have not used this scale hardly at all, but it's out there and there's research behind it. Tenetti. Tenetti is one you'll see quite a bit. Let me see if I can pull that one up. Grief allowable measure, both static and dynamic, usually for frail and elderly. 2 sub-tests of balance and gait. Let's see. Pull up. Please tell me this thing all just go wrong. So this is what the Tenetti looks like. And you've got a 0 or 1 or a 0, 1, and 2 in your ratings, okay? Total balance is out of 16. It's kind of like a bird balance test, but it's a little more simplistic, easier and quicker to go because there's 9 items, 9 tasks instead of 14. But it's pretty close to being similar.
So are these done in like initial eval or?
Actually, this one has more than that. It's got 16. I thought it was longer. What's that now?
When exactly are these like mainly done? Is this
Mainly,
like,
this is going to be, I'll tell you what.
is this like a primary
Sometimes it's
screen?
done at initial eval, but a lot of times as a PT, we got to do so many other things in terms of ruling out stuff and checking other comorbidities. A lot of times we put this on to the PTA and say the second visit you're going to come, you're going to do this test. Okay, so that's why we want to show you these things, so you're familiar with it. So again, 16 items here. This is for the gait part. The other part was the balance part. Again, don't sit here and memorize, just make sure you're familiar with these things, okay? There we go. So, the things that I would remember are these interpretations down here, okay? Because again, you're not gonna remember all the tasks that they have to do, but I think it's reasonable. And again, the boards are gonna expect you to be able, if they give you someone is a medium fall risk, where are they gonna fall on these tests? Shoulder rating questionnaire, again, not one that I used very much, but you will see that one from time to time. This is the one that's become much more used in the clinic, the DASH. There are 30 items here, ranging from pain to ADLs, all kinds of stuff. Recreation, sexual activities. They love it when you ask them about their sexual activities, people. They love that. I've gotten some of the best responses you will ever imagine when we start talking about this. But anyway, this is going to be a score out of 100. The higher the score, the greater the disability. Okay? So if they score high on this, that means that there's problems. Okay? There is a modified quick dash that is only 11 items. Let me pull up a copy of the dash for you to peruse as well. This is one that we used in our clinic. It's very easy. Again, it's 30 items though, so it takes a little bit of time. But you can see these are pretty much all activities that you could do almost any time, any place. I feel less capable, all that kind of thing. The scoring on this one is a work module, there's a sports performance module. You don't have to worry about that. The actual dash is 30 items, and that's what's been researched greatly. Lysholm knee score, 8 domains, talking more about gait, limping, use of assistive devices, all that type of thing. Here's the interpretation here. The higher the score, the better with this one, okay? It was originally designed for ligamentous injuries of the knee, but you're going to see that one pretty frequently. This is the oswestry that we talked about earlier. This is the gold standard in terms of trying to quantify low back pain and disability. I'm going to pull that one up because that's one you'll see as well. Uses a 0 to 5 scale, 8 domains. This one takes a little while. You can look through here. Again, most of this stuff is common sense, but the great thing about all these is they have been researched. They have been tested on numerous people, and the scales have been tested for reliability and validity, and that's why I picked these, is because they have good outcomes with them. So again, 10 items on this. You scale it, you can go through it. I've had to read this out to people who don't read very well. Some people will throw it at you and say, I'm not filling it out. You can decide what you want to do with that. It's not always easy, to say the least. They get tired of doing these things. That's why we didn't do them very often. So for the oswestry, 0 to 20 is minimal disability, 21 to 40 moderate, 41 to 60 severe, 61 to 80 crippled. I didn't even know they use that term anymore. 81 to 100% bed down or exaggerating symptoms, because that happens as well on these things. Texas women for low back pain, haven't seen very much, don't worry about that one. Board rate of perceived exertion scale. How many of y'all have dealt with this before? Maybe in exercise phys or what have you. This is one that you're going to see quite frequently. This is a subjective test for measuring physical activity intensity level. Patients active rate perceived exertion during an intensity level of a daily activity, but it could be something that's more strenuous, if you will. The range is 60 to 20 on this scale, okay? The reason it's 60 to 20 is put a 0 behind it, and that should correlate with your heart rate. That's what this scale is designed to prove, okay? So if I have you walking on a treadmill at 3 miles an hour, and I say, give me a scale of your perceived rate of exertion from a 6 to a 20, and you tell me 10, then the studies are going to show that your heart rate should then equal close to 100 beats per minute, okay? That's the whole basis of this type of thing. They have a modified 1 to 10, 1 being really easy, 10 being maximum, but you know, 6 to 20 is the gold standard. That's what it was found. So be careful if you read a question, don't just assume it's a 0 to 10 scale, like the pain scale, okay? This is a 6 to 20 scale. So if you got somebody who's got a 7 on this, a 7 out of 10 in pain would be significant, right? 7 out of 20 on this, not so much. That's pretty much a resting heart rate, okay? Here is what you'll see in clinics. A lot of times when they're doing stress tests, exercise physiology lab, they will have this printed out for people to read and look at. Okay. Barthel's Index, gold standard ACL with great reliability and validity. 5 to 20 minutes to administer. Again, lots of different tasks here. The lower the number, the more dependency they have. You will see this one pretty frequently. Let me pull that one up and let you take a quick look. Again, you can peruse these at your leisure. So lots of just, you know, very common ADLs right here, right? You will see this a great deal in skilled nursing facilities, trying to get people discharging to a more independent setting. The Barthel is used quite a bit. The FIM, this one used to be, gosh, probably 20 years ago. This one came out, again, really good reliability with training on this test. But there was a clinic, not a clinic, a company called Photo. And if you see this, run the other way. Functional outcome, something, something. Anyway. The photo software and so forth, this was the one that you would come in and you'd have to fill out every time you walked in the clinic. And people were just blown away by this. I was doing some consulting for this healthcare system and they were using this photo. And we noticed that people quit coming on average like after 4 visits. And I was like, well, I'll tell you why that's the case, because you make them do this stupid index every single time they come in. People get annoyed with it because it takes 10 minutes. You know, if you're coming to therapy and you're spending 10 minutes doing this every time, that's 10 minutes you're not getting therapy, okay? So don't overdo that kind of thing, right? But the FIM is again, very well researched. Really good test. Here's the majority of this. If they grade out at a 6 or a 7, they do not need help. Moderate independence and complete dependence, uses a helper, 5 and below. That's basically what you got to get out of that. they need supervision if they're 5 or below. Pulses, you see what all this P for physical condition, upper limb function, lower limb, sensory, excretory, and support factors. All these are divided into motor and cognitive. This is an extensive profile here. I have never used this test, but I have seen a lot of research behind it, so I know that it's well supported. Health status questionnaire, very broad, 36 items, 12 in the short version. Again, lots of ADLs, emotional well-being, mental health, all that kind of thing. I think you're probably, with the emphasis on mental health, you're probably gonna see this scale used more and more. Let me see if I can pull that one up too. This is the 12 items, so this is a short version. Lift and carry groceries, climbing stairs, walking several blocks. How much difficulty did you have? How much did you accomplish? Social activities, bodily pain. Are you calm and peaceful? Do you have energy? Are you downhearted and blue, as opposed to being another color? Are you a happy person? So again, I think you're probably gonna see this more often than previously. The Folstein mini mental state examination. Never used it. Again, you're gonna see it more and more, again, with mental health being an emphasis. Falls, all right, so if we wanna talk specifically about falling, because a lot of these indexes have fall predictors with them. Falls an event which results in a person coming to rest inadvertently on the ground or other lower level as a consequence of a violent blow. So who falls? 30% over 65. If you take 165-year-old people that are just community dwellers and not incapacitated in any way, 30% of those are going to experience falls. If they are a patient, half of them are going to fall, and more than 50% if they're in a nursing home. Okay? Look at this number right here. 75% of slips, falls, and trips go unreported. Do you think that is because they don't get hurt? Absolutely not. Why do they not report them?
Because they don't want to be dependent.
They don't want to be dependent. That's a great, probably the number one. What else?
They feel like they didn't get hurt that bad, they don't want to pay no money.
They want to just move along and say, I don't, it's not a big deal. A little bump and bruise. What else?
They don't want to be in therapy longer.
They don't want to have more medical attention. They don't want more medication. What else? Money. Some of them are underinsured. What else?
Negligence.
Negligence. In what way?
Like in the nursing homes.
It's a possibility. Possibility. I can see that. How about embarrassment?
Yeah.
Big time.
You know what people are doing.
Big time. It's kind of the, my dad's 83 now, and I know he's fallen, and he didn't tell me about it. Yeah, I think it's just, I don't want to believe that I'm getting older type of thing, 25 to 89, how about that for a percentage? Good gracious, that's ridiculous. Of hospital adverse events are fall related. That range is so ridiculous. That's like saying 0 to 100. 0 to 20 fallers fall repeatedly. If you're gonna fall once, what's the biggest predictor of another fall?
If you fall.
The first fall. The first fall. Because if you fall once, you will fall again. Risk factors. We say extrinsic. What does that mean? Extrinsic risk factor. The environment around you, right?
Rugs and pets.
You're gonna fall more if you're walking through the forest or on a carpet, okay? You got uneven terrain. You got elements out there. You got weather conditions, you got wind, you got all kinds of stuff. Outside, that's extrinsic. Intrinsic, what are we talking about there?
Balance in itself.
Inner ear stuff.
Yeah, absolutely, all kinds of things to consider there. Strength, balance, coordination, agility, inner ear disturbances, sight, okay? If someone has bad vision, they might not see what's in front of them or around them. Okay, so there's a lot of things you got to think about there. The highest risk for falls. This, I think, is number one, and people really don't give it enough credit, to be honest with you. Weakness. Very rarely you're going to see somebody who has good strength that falls a great deal. Okay? Especially in the lower half. So, that being said, if we are working with someone in a clinical sense, and you see somebody that's weak, make them stronger. Make them do body weight exercises. Okay? Make sure that they can handle their body weight. If they can't handle their body weight, they need to lose some body weight. Okay? We can encourage that too. All right? History of falls, we said that's a huge component here. Gait deficit, we're going to see a bunch of those here in a few minutes. Okay? There's all kinds of things that happens with the gait cycle that puts people on the floor. We'll talk a lot about those. Balance deficits, again, things that you can think of, inner ear stuff, dizziness, tinnitus, where they've got the ringing in their ears. Sometimes they just get so focused on that they just lose everything else going on. Using an assistive device. We talked a little bit about this the other day. We're using something on the wrong side, or they're using a walker, rolling walker inappropriately. Maybe they've got a ledge that they can't see, or they've got to get into a room that's got a little lip or something like that. There's a problem there, okay? So we've got to look out for those barriers as well. Our fall-prone diagnoses, Parkinson's, almost 100%. And you'll see a gentleman with Parkinson's here in a little bit. CVA's at 50%. And again, there's varying degrees to all these things, right? Somebody can have a stroke and they can get up and walk around the next day and be fine. People who have massive strokes that never come out of it, okay? All kinds of stuff there. Amputees fall a great deal for obvious reasons. People who are just fallers, for whatever reason. It just makes sense. People with dementia, how about that? Think about that. Why would they fall more than other people?
I'm just wondering.
There's just an element of, I don't know quite where I'm at. Just
Like,
panic.
remember.
That's right, and they don't remember something that happened before that may have triggered that fall. It happens again. A pet running around or something like that. I've had all kinds of stuff people talking about. Consequences, fear is a huge one, okay? You will not believe when the elderly come into an outpatient clinic, and I didn't focus on balance at all. That's not what we did. But I would get people, and the number one fear that they would talk about was falling. Okay? You can't even imagine how many times the cascade of events, my grandmother was one of them, fell one time that we know, broke her hip, went and had, didn't have a total hip, had it pinned, never really healed, stayed in a nursing home, and had cascade of events, and she passed away probably 2 to 3 years later. Horrible quality of life after that one fall. So let's try to prevent it if we can. Obviously, lots of injuries can come as a result. Chronic pain, altered quality of life for sure. Expense, we already talked about that. If they're on a fixed income and they're repeatedly falling, they're not going to want to go to the doctor every time they fall, right? But they probably got to do something. And then mortality, we'll talk about those rates here in a minute. Fall prevention, huge part of what we do. Huge part of what we do, and probably even more so for a PTA than the PT, because you're going to get to spend more time with them on these things. Recognizing the danger. Again, we've already alluded to a bunch of these different things. Screen and assess further, reevaluate as warranted. If you've got somebody as a PTA, and this happened to my wife the other day. Lady came in, my wife is trying to move her, she's in a wheelchair, trying to move her from the wheelchair to the low table. She literally could not stand up and transfer. So my wife is having to get a gait belt and halfway pick her up. And I'm like, please help, she doesn't need to be in that facility. She needs to be somewhere else where they've got other additional means of transferring her. Hoyer lifts and all that kind of thing. We can talk about more this summer. But she then told the PT who had evaluated her, this is not an appropriate, well, she insinuated this is not an appropriate place for this lady to be receiving therapy. They concluded, because she was getting OT as well, that they really wanted to keep her at that Houston facility. Again, still not appropriate. Not enough of a reason for someone to stay. There's other places that she can go that can handle that type of thing. So you gotta talk, you gotta communicate about that. Reducing risk factors, we talked about the environment, behavioral things. If someone is fatigued, do they need to be out walking around the outside? If they're worn out? No. How about if they take their medications at the right time? If they're on a schedule, especially you're gonna see with Parkinson's people. I had our IT guy at our clinic in North Carolina was diagnosed with Parkinson's. And it was just amazing. He would come in some days and he couldn't move. He literally would be frozen in time. It would take him 10 minutes to walk 30 feet. Other times, if he was right with the medication and had it timed perfectly, you couldn't even tell that he had anything. So it is that dramatic, Improved what can be improved. Like we said, strength can be improved usually, right? We can usually improve an environment. A lot of times we can improve family education, talking to family members about, hey, you need to watch this, you need to get this rug out of here, you need to watch the pets, you gotta do things to put them in a good environment. Increase the level of assistance. This is when people, like Justin was saying, they don't want to hear this. They don't want more people coming into their home. They don't want to become more dependent. They don't want to lose their driver's license. They don't want to rely on others, okay? That's part of our job. That is part of our job to make those recommendations. Obviously, teaching safe behaviors, a lot of those we already alluded to. Just again, preach safety to these people. Because it can take one time. Fear of falling, we already talked about this. FOF, you're gonna see it. Devastating side effects, affects a willingness to participate. If they are prone to falling, most of them just sit around and watch TV because there's not a lot of risk there, right? Well, what does that do? Atrophy. Mental health goes down. Their weight goes up. All of these things become more problematic, and it just starts snowballing. Okay, you have to think about those things. Performance-based assessment is more reliable than self-report. That's why we talked about those functional indices previously. You've got to have something to quantify it. Balance. 3 types. Static, maintaining a position. Dynamic, being able to voluntarily move. And reactive, which is probably the most important. Okay? If I throw this bottle, look what she did. She caught it, right? She reacted to this. So there's going to be an ability to react to some type of external stimuli. If they can do that, and you can train that, which you can, they have a much better chance of not falling and having better balance outcomes. Here's all these tests. We just talked about most of them. Does Houston use anything in particular in terms of a balance screening? Because you don't see much of that.
No, I mean, the only thing we really use is the tug.
So
And
time
that's
up and
rare.
down. Yeah.
That's rare.
Yep. Alternatives to manual muscle testing. Should be everything. Strength exceeds its functional threshold. Strength of patient greater than the therapist. Power endurance needs to be measured. Those are huge. More common alternatives to manual muscle tests are the equipment-based tests. how many bench presses can you do, that type of thing. Need to pre-screen, warm up before testing, of course. We're gonna always wanna warm up beforehand. 1 rep maximum test. Again, a lot of you guys have studied exercise science and so forth. 1 rep, or you see a 1-RM abbreviated like this, that is a gold standard in standardized strength testing. The amount of load a patient can move 1 time through a full range in a controlled manner with good form. Now, are we gonna do this on a majority of the patients we're working with? No. If you are in a Olympic training center or something like that, you're gonna see a lot of this. Okay, so as your skill level and your at more athletic populations that you see, you will see this type of thing. Okay, they are relatively safe but can result in soreness. They tend to be very reliable and precise, and they help to prescribe exercise. Put them in the right progressive resistive exercise program. We will talk a lot about this summer. Okay, just wanted to introduce that. The technique, don't worry about that right now. If you look at 80% of a 1RM, this is how many repetitions they should be able to do based on lots of research. Okay, don't sit here and memorize those things, just have a common sense approach with those. Isokinetic testing, we talked a little bit about this a while back. This is a KenCom or a Biodex or what have you. These are $50,000 to $80,000 machines that you really won't see in the clinic much anymore. They take up a bunch of space. They can only really work in single planes. And muscles don't contract isokinetically. What does isokinetics mean? Isometric means constant load. So isokinetics is going to be constant speed. Okay, we don't move like that. Okay? These are mainly used for diagnostics and to, you know, after someone has an ACL reconstruction. This was our protocol before. They had to go do isokinetic testing on quads and hamstrings to see if they were 60 to 80% as strong as the uninvolved side. When they could do that, then they could start running and starting to get back into sports and things like that. But that's about the only time that, do you see isokinetic, do Houston have?
We do Biodex on all our ACLs.
ACLs get Biodex, they still get it across the board, every doctor?
Majority of them, yeah.
Majority of them.
I think it's just because we have the machines, so why not?
Yeah, yeah. Handheld dynamometry, we've talked about this, we've even demonstrated. This is much better than manual muscle testing. The only problem is it's expensive, okay? That handheld dynamometer, ours costs like $1,400, okay? So, not a lot of people are gonna buy these for a clinic. It's great for research though, really, really good for research. Absolutely a must for that. Limitations, skill, you gotta be consistent with your placement, and there are not many norms to use in comparison here. Power testing, trying to measure force production and the rate, things like the hop test, vertical jump tests. Again, these are good tests, really good tests, very well researched. They just, you know, you're not gonna have your grandma in the walker doing the hop test or the vertical jump test. Again, this is gonna be more for your athletes and so forth. All right, so let's take 10 minutes, and then we're gonna do about an hour of gait videos. So come back.